Good day, everyone. My name is William Brady. I'm from the University of Virginia, and we're going to talk about wide complex tachycardia today. This is part 3 of a 3-part series of lectures. You can find the other lectures, parts 1 and part 2, in the course description. Just follow those links if you have an interest. So in part 3, we are going to talk about SVT with aberrant conduction versus VT and basically work through a diagnostic algorithm that helps you come to a diagnosis as well as make decisions about the most appropriate therapies. So here is the algorithm or the flow chart. Looks pretty complicated, not really, and we're going to take it step by step. So you're taking care of a patient who presents to you with a wide complex tachycardia. Of course, this is the adult patient we're focusing on, but in general, the concepts could also apply to the pediatric patient. So you have a wide complex tachycardia patient. You're looking at the rhythm strip, the cardiac monitor, the 12-lead ECG, or some combination of those ECGs. First decision you need to make in terms of diagnosis, which has direct implications on the most appropriate treatment, is could this be sinus tachycardia with pre-existing bundle branch block pattern? In fact, that's the most common wide complex tachycardia we see in emergency care today in the United States. Other forms of sinus tachycardia that can have a widened QRS complex include hyperkalemia, elevated serum potassium, as well as various toxin-induced rhythms, particularly patients that have purposefully or accidentally overdosed on sodium channel blocking medications, which will cause a wide QRS complex. Of course, if we have sinus tachycardia with bundle branch block, hyperkalemia, or sodium channel blocking effect, the so-called toxin-induced rhythms, then you're going to want to identify that and treat the underlying issue. Okay, so sinus tachycardia with bundle branch block, is the patient hypovolemic? Is the patient hypoxic? Is the patient having significant pain or anxiety? Is there some sort of toxic effect of a medication, et cetera, et cetera? We're going to want to identify those issues and treat the underlying problem accordingly. If we have hyperkalemia, let's definitely identify that and think about the various treatments aimed at reversing hyperkalemia. And then, of course, again, in the same setting of somebody with a sodium channel blocking drug on board that has produced a wide QRS complex, let's think about that. And remember, one of the primary antidotes in that setting is sodium bicarbonate intravenously. So very important to identify this group of wide complex tachycardia patients and treat the underlying problem. Now, when we've removed those from consideration, we're left with AVRT, which remember is the wide complex tachycardia encountered in wolff-parkinson-white syndrome patients. So it's the antidromic atrioventricular reciprocating tachycardia. That's one of the possibilities. We could have AVNRT, so AV nodal reentrant tachycardia. That's a more formal name for what many of us refer to as PSVT with a bundle branch block pattern. And of course, you can have atrial fibrillation or atrial flutter with bundle branch block pattern. So a range of supraventricular rhythms with wide complexes likely due to bundle branch block or other issue. And of course, ventricular tachycardia is still in the mix as well. So the next identification and decision point is identifying the entity that is now referred to as complex atrial fibrillation or atrial flutter. Now, I'm going to include atrial flutter in this talk on this particular subtopic, but for now on, I'm just going to refer to it as complex A-fib. So that includes A-fib and A-flutter. So what is complex A-fib? Complex A-fib is A-fib with RVR, so rapid ventricular response, so rapid A-fib, and another significant physiologically stressful event occurring. So this would be AFib with RVR in a patient with sepsis, and highly likely sepsis with septic shock. This is somebody with a significant hemorrhagic issue like an upper GI bleed, somebody with a pulmonary embolus, a patient with severe alcohol withdrawal, et cetera, et cetera. So complex AFib really describes not only the rhythm itself, AFib with RVR, but the clinical setting in which it's occurring. And that's very important to identify because the typical treatment approaches we have for AFib with RVR, which include our rate controlling drugs like intravenous diltiazem and intravenous metoprolol and electrical cardioversion for unstable patients, may not always work appropriately and could potentially cause harm in these complex scenarios. So taking sepsis as an example, if we have a patient that has pre-existing or newly noted AFib that is presenting with a rapid ventricular response in the setting of severe sepsis, we're going to want to treat the patient's sepsis. We're going to want to volume resuscitate them, give them normal saline or Ringer's lactate intravenously to build up their vascular volume. Potentially think about a vasopressor like norepinephrine if we're not making appropriate progress with the IV fluid. We probably don't want to give diltiazem or metoprolol early on in this setting because that's going to make the problem worse rather than better. And also, frankly, attempting electrical cardioversion if the patient's unstable. They're unstable not just due to the AFib that's rapid, but they're unstable because of the septic shock in our scenario. So let's identify the complex settings in which atrial fibrillation with RVR can present, identify that as complex AFib, and really, at least initially, focus on the underlying issue, the sepsis, the GI bleed, the pulmonary embolus, the alcohol withdrawal, et cetera, et cetera, et cetera. So once we've removed those entities from the differential diagnosis, we're now dealing strictly with wide complex tachycardia, okay, and no other active issue occurring. So again, the WPW-related antidromic AVRT, typical AV-NRT, which again we refer to, many of us refer to as PSVT, and then atrial fibrillation and atrial flutter, of course, with bundle branch block pattern in a non-complex setting. So what does that mean? That's AFib with RVR or a flutter that's rapid in a patient with no other significant physiologically stressful issue. So those entities as well as VT. What we're going to do there is treat the rhythm according to the clinical presentation and stability. You know, if in doubt in these settings, once we've removed sinus tachycardia with bundle branch block and complex AFib from the differential diagnosis, then any of these other rhythm possibilities in the wide complex tachycardia presentation can be treated with synchronized electrical cardioversion if they're unstable, or if they're stable from a hemodynamic standpoint, we can use intravenous procainamide, okay? A great drug, very appropriate to use, and quite worthwhile. And that's actually a nice segue to this one article I wanted to mention to all of you, published in the European Heart Journal in 2017. It's referred to as the ProCameo trial, and it basically is a comparison of intravenous procainamide with intravenous amiodarone in patients that have a wide complex tachycardia with a pulse who are hemodynamically stable. And in this study, the investigators found that procainamide outperformed amiodarone in two ways. Number one, it had a greater rate of tachycardia termination as compared to amiodarone, and it had fewer adverse effects. So procainamide really is quite an older drug that's been around for a long period of time, but it's also quite useful. So always think about this in your hemodynamically stable wide complex tachycardia once you've removed those other entities that we've talked about. Frankly, the only failing of procainamide is you can't give it too rapidly, okay? We know that amiodarone in a patient with a pulse, we need to give over 10 to 20 minutes in a slower infusion, certainly not the IV push that we use with amiodarone when a patient's in cardiac arrest. Procainamide, we need to give much more slowly, somewhere in the order of 45 minutes, give or take a couple minutes. If you give amiodarone too rapidly, it will precipitate hypotension and can actually further impair conduction in the ventricle with widening of the QRS complex further. So we want to be careful with both of those issues, which are really related to the rate of administration. So think about procainamide. It's an older drug, but it's definitely worth having in your armamentarium to care for patients with stable wide complex tachycardia. Management issues in general, let's treat the patient and the electrocardiogram, not just the ECG. Many of us, myself included, sometimes get all wound up, get our knickers in a twist, as they say, when we see a wide complex tachycardia. What is it? What is it? What is it? What are we going to do about it? Well, let's look at the ECG and let's look at the patient. You know, considering the algorithmic approach that I just suggested, it helps you work through the various steps and stages of this presentation and highly likely do the right thing. Remember that VT occurs in older patients, particularly those with a compromised left ventricle, meaning past MI, significant chronic heart failure, multivessel coronary disease. So that's the kind of patient that develops Vtach. We do see Vtach in younger people, including children, but it is very uncommon. Also, remember, SVT with aberrant conduction does occur in older people and younger people. Okay? So we really do see both categories of rhythms all across the age spectrum. Recognize that sinus tachycardia with bundle branch block, hyperkalemia, and toxic effects, as well as complex A-fib, do present and probably need to be treated differently than electrical cardioversion or intravenous procainamide. In each of these presentations, we're going to want to identify the underlying issue and treat it accordingly. Okay? For the rest of the rhythm presentations, once we remove those entities that we've mentioned in number 3 above just now, if in doubt, assume Vtach and treat it accordingly, which could be electrical cardioversion in the unstable patient or intravenous procainamide in the stable patient. Thank you so much for your attention. Hopefully this was of some value to you. Here's my email address. Do not hesitate to reach out with comments and/or questions. Stay safe, and thanks for what you do. Take care.